Good afternoon, everyone. Just letting you know we'll begin in a minute, and we're just allowing people to come into the webinar, so we'll start very shortly. Okay, so we'll get started for today. Thank you very much for coming and welcome everyone. My name is Carla Seaman. I'm a research fellow at the Australian Institute of Health Innovation, and I work with the Aged Care Evaluation and Research team here. Welcome to our AIHI webinar series with Professor Kathy Eagar, speaking on using research evidence to improve Australian aged care funding, staff ratios and public reportings. I'd like to acknowledge the traditional owners of the land on which we gather and pay my respects to their elders, both past and present. And I'd like to extend that respect to all Aboriginal and Torres Strait Islander people with us today. So just an introduction about our speaker today. Professor Kathy Eagar is a Professor of Health Service Research, Director of the Australian Health Service Research Institute and Executive Director of the Australian Palliative Care Outcome Collaboration. Now in its 16th year, the Palliative Care Outcome Collaboration is funded by the Australian Government as a national program that is fundamental to the delivery of palliative care in Australia. In addition, Kathy is also an Executive Director of two other Australasian outcome centres, the Australasian Rehabilitation Outcome Centre and the Electronic Persistent Pain Outcome Collaboration. She's authored over 500 papers on management and quality outcomes, information systems, and funding of health and community care systems. So here at Macquarie University, the Aged Care Evaluation and Research stream that I work in, we specialise in working with aged care providers and older adults to explore aged care administration data that is collected on a day-to-day basis for operational purposes to help inform quality improvement strategies and support in increasing the quality of care and quality of life for older adults, with particular reference to medication administration data. Hence, we have been following the amazing work of Professor Eagar has been conducting in this space. And this seminar will provide an overview of the research undertaken by the Australian Health Service Research Institute at the University of Wollongong that formed the basis of 3 key recommendations from the Aged Care Royal Commission. All 3 recommendations have been adopted by the government with implementation plans as part of the May 2021 federal budget. This included designing a new classification and funding model for the residential aged care called the Australian National Aged Care Classification that will be implemented in 2022. And they also undertook research commissioned by the Royal Commission on mandated staffing ratios and on the need for public reporting. Progressive implementation of both is also beginning in 2022. So just before I hand it over to Kathy, if you have any questions, please add it to the chat as we go along and we'll have a discussion at the end. The presentation is being recorded, but it doesn't show the names or faces of the audience. And everyone registered for this event will receive a notification for our next webinar. So handing it over to you, Kathy.
Thank you. And I will share my screen. Good afternoon, everybody. And I'm happy also to say that I'm happy to provide a copy of this presentation to participants afterwards. What I'm going to do is really talk a little bit about the Aged Care Royal Commission and then talk about the work that we've done and finish with some general comments about where I think it got to. But I want to start with an obvious statement, and this is picking up that the first report from the Royal Commission was called neglect, and that was a perfect word. The aged care system we have in Australia is really very shoddy. There are some very, very good providers, but there's also an awful lot of terrible providers. and most people have no confidence in the system for very good reason. The Royal Commission that happened had the single largest number of public submissions. It had 18,000 submissions or so. And that's really a sign of just how frightening people find the system. It has been essentially a system that is unsafe and unkind. And the Royal Commission was commissioned to try and really work out what the problem was and work out what the solution was. And the first report was called Neglect, and it worked out what the problem was. And the second report was meant to work out the solution, but it didn't. And I'll come back to that at the end. I want to pick up what Carla just said about two studies that we did. We're doing a very large project called the RUX project. We got a $2 million grant for this one study, and we were doing that. And then we were actually then approached by the Royal Commission, and the Royal Commission was very active in finding the right research, well, I hope the right research groups, and they commissioned us to do work for them on staff ratios and star ratings. I want to start with this general schema about if you want to improve a system, what can you do about it? Well, if you want to improve the system, you've got a couple of options, and they start from the left-hand side. You can do something about inputs. And in my career, I've never historically done much on inputs, but that's staff levels and mix and all those sort of things. The second is processes, and the Macquarie Group, we were just hearing a lot of the processes of care, medications, etc., are in how to drive process improvement. And that assumes that if you improve process, you improve the next two. Most of my career has been in outputs and outcomes. And in that introduction that I run 3 large national Australian New Zealand outcome centres in chronic pain, rehabilitation and palliative care. And in fact, we're about to open another, which is in palliative aged care. So across that care continuum, you can intervene at any point to try and improve the system. And sitting underneath that, of course, is that there's a large platform of legislative and economic and policy contexts, and also some key intersections. When we did the work which culminated in what's called the ANAC now, the Australian National Aged Care Classification, we were really commissioned to do work about outputs. But what we understood, because we've been doing this work for a long time, was that if we did it right, we could also inform the future thinking about inputs and outcomes. And it was that work that we were then able to do for the Royal Commission. So the ANAC was designed to both pay fairly for outputs, but it's also proved to be a very useful model to understand inputs. And I'm quite happy to talk you through some of that in questions and comments at the end as well. So if I want to start first of all with the care needs of residents, and I will just go back and say here I'm going to really talk today about residential aged care, not community aged care. And only because I think there wasn't enough time in the context of doing one seminar today to talk about both. So the history of the residential aged care sector was that it was formed by bringing together a low care sector or hostel level sector, which was regulated by the Commonwealth, and a nursing home sector that was regulated by the states and territories to form a residential aged care sector. And that was merged 7 or 8 years ago to form one sector. And the fundamental problem is that the Commonwealth has continued to regulate and fund it as a low care sector when everybody in it is now high care. So you've got this massive mismatch. But I guess I'd be arguing that if you want to actually get staffing right, get quality right, get payment right, you actually have to start with what do people look like, what do they need? This is my opening slide, and this is to say the more successful we are at addressing the social determinants of health, the more that we increase life expectancy, the more business there is for the aged care sector. And I think that's really, I remember about 20 years ago reading the first ever paper on the compression of morbidity. And this was the idea that if we all had lived healthier lifestyles, we would compress the period at the end of life into a shorter period. And this would save money and less people would become dependent. And this was the economic argument for investment in prevention. And I followed that evidence now for the last 20 years, and there isn't any evidence that you can compress morbidity. What you see in this slide is that there are 180,000 aged care beds in Australia and about 240,000 people a year going through those beds. And that's because each year 60,000 people die and another 60,000 take their place. And indeed, 1 in 3 people who die in Australia each year are living in residential aged care at the time of their death, although they don't necessarily die there. If you look at that very old age group, what you see up to about 75, very small numbers now and equal numbers of men and women. And as you go up in 5-year cohorts, you see the men going up and forming a very nice little normal curve there, but the women predominantly going into very old age. And we now have 30,000 people a year in aged care who are 95 or plus, which is an extraordinary number. But look at the 90 to 94-year-old women. We have nearly 45,000 women in that age group. We also have 4,300 people who are over 100, including 8 of them, I thought you'd be interested to know, who are 108. So 2/3 of all the women in aged care are, 2/3 of all the residents in aged care are women, and 80% of the workforce in aged care is women. And so typical women's business, this is a sector that is badly neglected, with staff being badly paid and not recognised for what they do. This is what the frailty profile looks like, and the data I'm now showing you are from our study where we developed our own assessment system to identify what people need. We engaged our own clinical assessors, a big pool of people, registered nurses, OTs and physios, and they assessed several thousand people for us. If a person was terminally ill, we terminated the assessment there, and you'll see that for the 9 group, and this is the Rockwood frailty scale. Are not here because we did something else with them in our study. But this is the overall frailty of this sector. It's a very small sector. Only about 10% of people are actually physically fit, and almost all of those have young onset dementia of quite profound types of dementia. But this is not a healthy profile. One of the things I hear all the time is we should be investing more in community aged care to allow people to go to not go to aged care. When we go and look at the sector, there are very few people we see who could live it. Well, there's almost nobody that we found that could actually live independently at home. We already have a system where people are voting for their feet. Nobody is going to aged care by choice. They're going because they've got no choice, and they are extremely frail and highly dependent at entry. So this is what the profile looks like for people in terms of their self-care needs. 80% of people need help with basically bathing and dressing and grooming, and even with eating, and that's putting food in front of somebody already prepared for them and plated. 2/3 of people still need help with eating a plated meal. This is not a cohort who can live at home, and we have to really start challenging this idea that we need to invest more in community in order to keep people out of residential aged care. People are already not, the people who are in aged care actually need to be there. This is what the continence and transfer profile looks like. 70% of people needing help with continence and transferring. And I guess just to add to those previous comments about people not being, looking at the future of residential aged care, there are all these people who think we're going to reduce the number of residential aged care beds in Australia. I think we're going to increase it. And I'm happy to talk about that at the end as well. But the idea that, you know, the olden view that the oldest daughter stayed home and became the spinster who looked after mum and dad, that's why people didn't need aged care. Those days are gone, and we have to think about what a better aged care future looks like for the baby boomers, my generation and beyond. This is what communication and social cognition looks like among this cohort as well. We're talking about 2/3 of people needing assistance to understand and express their needs, and 80% or so needing help with social interaction, with problem solving and with memory. And this is in a sector where all the talk of the sector is about consumer-directed care. So we've had this set of rhetoric about voucher-style individualised funding, consumer-directed care, and then you look at the cohort where people we're talking about, you're talking about a very dependent cohort. So that takes me into the ANAC, the Australian National Aged Care Classification, We did develop it in a study called the RUX study. So this is just a few acronyms, and at the end I'll give you a reference for people wanting to read about it. We did a series of studies. We did 4 as part of RUX. We did a service utilisation classification development study. We did do a costing study looking at what are the structural costs of having the door open in an aged care home versus the cost of care that are attributed to individuals. We did some Casemix work, and one of our major centres here is the Casemix Centre. And we went back and we reassessed people 4 to 6 months after we first assessed them to look at the rate at which people change. And again, I'll give you those web addresses at the end. The key outcome of that work is the new Australian National Aged Care Classification. It's a Casemix classification. It's designed to replace the current funding model, which is called the Aged Care Funding Instrument, or the AHSRI. There are only 13 classes in the new system we have developed to replace 64 classes in the AHSRI. And assignment to a class is based on a person's capacity to manage activities of daily living. We also developed a new funding assessment tool, and the data I just showed you are from items from that tool. And we developed a new funding model that's got 3 elements, and that's called a base care tariff, and I'll show you that in a second, an individual payment for a person, and also a one-off adjustment. And as it's just been announced, the government announced in the May budget that ANAC is being implemented nationally from October 22, and the ANAC assessment process to assess all the current people in aged care has already commenced. And over the next 12 months, the 240,000 people going through the system will be assessed using the new assessment tool. So this is quite a study now in implementation. There are 6 core elements to the new model we've designed. The first is in some ways the most important. The way the system works now is that homes assess people using an AHSRI, and that's the aged care funding instrument, and it's an additive instrument. There's lots and lots of items, and the idea is to score as many points as possible, because the more points you get, the higher the payment. And the problem with that is that the AHSRI has been skewing assessment for care planning for a long time. The AHSRI has also been creating perverse incentives for things like you get more points if the person has a pressure injury. So we've been really trying to deal with some of the perversity in the current model in the design as well. The second element is that care planning needs better assessment, and it should be based on needs, strengths and preferences rather than just a deficit model to get you into a high-paying AHSRI class. The third point is that the new assessment for funding should be as parsimonious as possible. It is undertaken by external assessors, capturing just the information necessary to get you into a payment class. And our criterion for success for that was that an independent, experienced clinical assessor could assess a person they didn't know in less than an hour at first meeting, and we actually achieved that in the tool, so we're really happy with that. The next element is that we did actually look at this whole issue of when somebody first enters care, that first initial period, they experience higher costs, that there are additional but time-limited resources getting to know the person, doing a care plan for them, sorting out their pain, getting their medication right, getting to know them, their preferences, their families. We actually did do resource charts for each person, and we looked at that adjustment period. It's about 4 months actually for the average person if they haven't died in that time. But we have actually proposed a one-off adjustment payment. Importantly, if a home can improve somebody's function during that adjustment period so that they actually stay in the higher paying class that they were in. So there's a very distinct incentive in that first period. If somebody arrives and they've been deconditioned or they've got malnutrition, and you can make them all independent, in that early period, you get to keep you get the benefit of that. We did discover that there is a very large proportion of time in aged care where the costs are fixed. So every home in the country has already got a night staff rostered on for tonight. And that is the case irrespective of the individual needs of the residents tonight. And so we've got a funding model that's got two components. One is a fixed per diem price, a fixed per day cost for the costs of care that everybody gets an equal benefit from. And they do vary a lot by location. And then the second is an individualised variable payment per day based on one of 13 classes, and that payment is standard across Australia. So in terms of the base care tariff, which is the fixed cost, that's really the shared cost. We had 4 expert clinical panels, and we said, let's just speculate. What percentage of time do you think that staff spend is shared by all the residents equally? Supervision in the dining room, the night shift, writing up the notes, all those sorts of things. And the expert nurses we had from working with us from aged care said, it's going to be about 50-50. Well, it turned out to be 51-49. So they knew we didn't need to do the study. We could have just asked them. So we're paying for that shared care in what we're calling a base care tariff. And then we pay for the other 49% in an ANAC payment. These are our base care tariffs. We have 6 levels, and these are a set of relativities. And this is the fixed cost to have the door open. And imagine that the IPA, the Independent Hospital Pricing Authority, is about to become the Independent Hospital and Aged Care Pricing Authority. And imagine that they set the price for the base care tariff at $100. Then for an Indigenous home in the most remote part of Australia, in the MMM7 modified Monash method 7, which is rural and very remote, if the average payment is $100, then for base care tariff 1, they'd be paid $463 a day simply to have the door open. So from the bottom, the average is $100. For base care tariff 6, which is Metro, basically, it's $95. You'll see there's a very large base care tariff increment for homes that specialise in homeless people. They get $179 compared to $100 for the average. And you'll see the rest, the predictors of the structural costs of having the door open were specialised homeless, Indigenous, remoteness and size. We also looked at some other variables in the model. For example, we expected to have a separate base care tariff for dementia homes. That wasn't the case. It was also not the case for specialist homes in mental health or in palliative care, and I'm happy to talk about that at the end. When we looked at the individual sides, diagnosis is not driving costs, and so diagnosis-related group type ideas don't work out of health. But what drives costs for an individual is what the person is capable of doing, not just their physical capability, but also their cognitive ability, their mental health issues like motivation and their behaviour. And our assessors were trained to assess a person's capability to manage activities of daily living, taking into account their physical, cognitive, mental health and behavioural issues. And thus it's capturing the health, the health consequence, the functional consequences of health conditions like dementia. People with dementia don't get into the independent groups because they haven't got the cognitive and behavioural, often in many cases, abilities to manage independently. This is the classification. It's got 13 classes. The first class is for people who are admitted to aged care specifically to get end-of-life care defined as the last 3 months. Set that group aside and you'll see the very best predictor of need for care is how independent a person is, and that is their mobility. Headlines up, only 15% of people in aged care are independently mobile. 50% of people need assistance with mobility, and I don't mean an aid or appliance, I mean another person working with them. And 35% of people are non-mobile. This is a much more dependent population than most people understand. For the 15% of people who are independently mobile, there are two classes, class 2 and 3, defined as with and without compounding factors. And those compounding factors are behaviour, cognition, functional abilities, and a whole lot of other things in an algorithm. For the group in the middle, the assisted mobility group, the very next split, the best predictor for that group is how cognitively impaired they are into high, medium and low cognition. And again, splits into with and without compounding factors. And for the 35% who can't mobilise, the predictors that best predicted their need for care are function, their risk of a pressure injury. So you don't get into that group because you've got a pressure injury. You get in there because of the risk of pressure injury, and again split into with and without. So that's the 13 classes, and I decided not to really put up a lot of detail about what the compounding factors are, but they're all the things you would expect to see in terms of functional ability, cognitive ability, behaviour, and also need for technical nursing. Each of those classes has residents who've got very similar needs for care, and we were able to test this by looking at a whole lot of factors, and therefore the classes are the item that have been used to predict staff time. And the government has announced new staffing ratios, mandated 200 minutes. So the mandated that they've announced the 200 minutes is actually adjusted for what ANAC class people are in, and we've done the technical work on how to do that adjustment. Each of the classes contain residents who cost about the same to treat, and therefore you can use it as a unit of payment in the new funding model. And the third is that each of the classes represent residents whose clinical risks and outcomes are very similar, and therefore you can use these classes to risk adjust for quality and safety using the same sorts of approaches you would use to standardise mortality, where you'd adjust for age and sex. You can now use these 13 classes. On this slide, I've got the same 13 classes from before, but I've actually now added a percentage. If the average staff time is 100%, have a look at class 1. On average, people in that class get 72% more staff time than the average. And if you look at class 2, people in that class get only half, 52% of the staff time. So when staff ratios are introduced, it's going to be 200 minutes is going to be the average, but the amount per is going to be determined by the class that the person's in. So if you just keep that figure in mind, what you'll generally see is that the without compounding classes get less staff time than the with. In other words, the compounding factors are actually driving some staff costs. So if you look at classes 2 versus 3, you can see it's 52% versus 70%. And if you look over at class 12 and 13, these are people over here in classes 12 and 13. These are people who are not mobile. They've got low function and they're at high risk of a pressure injury. The group without compounding factors don't have any other major things going on, but they're 45% more expensive per day to care for. But class 13, they're not mobile, they're at high risk of a pressure injury, and they've got some other issues. 72% are getting, on average, 72% more. So when we start to think about quality of care, there's two issues. One is how big is the 100%? How many minutes does that represent? And the second is the relativity between the classes, right? And how might you change that? In this slide, I've just changed onto, it's the same thing, except this time I've just got registered nurse care minutes, so not total minutes. And we've done this for each of the professional groups. So for total time, it was 172 for class 1 and 52 for class 2. And when you get to registered nurse minutes, it's 168 versus 62. So I'm just looking at classes 1 and 2. And this is allied health. The allied health minutes go in direct opposite to the personal care workers. The allied health staff that are in aged care are spending most of their time with people who've got more functional abilities. And so you see this in things like in class 2, which gets very tiny amount, 28% of all the care workers. They only get 28% of the average aged care worker time, but they get 116% of allied health. So this is a way to start to agree and define appropriate care. So this last one is my care worker one. And you'll see the relativities are very extreme and they are the major cost driver, of course. When I move very quickly to the staff levels and ratios, guess what? Major surprise, we found a direct causal relationship between the staff number and skill mix and quality and safety. The international literature is really clear about this. The 4 major predictors of quality and safety in aged care are staff numbers, staff skill mix, we don't have enough registered nurses, staff continuity, agency nurses and use of large casual pools is a major problem, and also clinical governance. So they're the sort of 4 predictors. We did an international literature review and identified the American 5-star rating system as the best, and it has 2 measures for staffing. One is total staff time and the other is registered nursing. And you'll see across the top here, the total staff, and the next item is minutes. If you get under 186 minutes, it's 1 star for total staffing. And you'll see in the rows, registered nursing, you get 1 star if it's less than 19 minutes. Across Australia, when we did this study, Australia averages 2 stars. And that is 1 star for total staffing and 3 stars for nursing. And that worked out pretty much the same across homes, although I have to say that the smaller homes do better. 56% of small homes, this is beds here, are 5 stars compared to 28% of the large homes, the 75 bed homes and up. This piece of research we did led to this campaign by the Nurses Association, and it was a good headline. 58% of all people in residential aged care are in homes with only 1 or 2 stars. And it's the first and only time in my whole career that I can point to something in the American healthcare system and say that they do it better than we do, but they do. This is the American 5-star rating system, and the blue is how those stars split in America, and the pink is what it looks like for us. And that's the 56% that the Nurses Association ran their campaign on. So in terms of, I've got a couple of slides and I'm very close to the end. The first is that the government did respond by throwing a lot of money at aged care, 17.7 billion. And you'll see the carve up, basically 7 billion also for home care. That's to increase the volume, 7.8 billion to increase the staff ratios and make the sector more sustainable. Most of our work is in that 7.8 billion. And you'll see the other 3, some money for workforce governance and quality and safety. Note the box though, there are 3 claims currently before the Fair Work Commission towards the end of the year, seeking a 25% pay increase for aged care workers, not just personal care workers, but also the nurses. The Commonwealth made no provision for funding increases for staffing in the budget. They also chose not to be a party to the case. And if those claims were to go through, you're talking about something like 4 billion per annum, which is this, you know, they just announced 17.7 billion over 4 years. So that's only 4 billion. Those claims alone would double that bill. What they did in terms of our staff ratio work is that they announced 200 minutes a day, and you'll see that's right smack in the middle of being still 2 stars with 16 hours of RN time a day. So the nurses went for 24 hours nurse coverage. They got 16, but it's not exactly like we're now funding best practice. We're still funding the bare minimum of adequate practice. So I guess my way I would sum up the Royal Commission is to say that I think the government picked the lower hanging fruit and they threw a lot of money at it, 4 billion a year. But I think there were 3 fundamental areas where they failed. One is I don't think either the Royal Commission recognised adequately, and the government certainly hasn't, that we can't fix aged care while we think that we're going to do that through a competitive market. without recognising that aged care actually has to be considered and regulated as a public good and not just a competitive market. The market has failed and it's going to continue to fail in aged care. The second, I think, is that you can't improve aged care until you improve funding, accountability and regulate profit. And the Royal Commission made a decision not to recommend the regulation of profit, a decision I strongly opposed and still do, and that let the government off the hook. And the third, I think, is that you can't improve aged care unless you understand that people don't need aged care because they're old. People need aged care because they develop health conditions which result in functional decline, and that the only way you can improve aged care is to bring together aged care and healthcare for older people. So I think those three big issues remain on the agenda for this next election and probably beyond, I think. I really do want to pick up and say I think that a proper aged care system would actually give equal weight to 5 domains of health, of function, of social, of residential and palliative. And I don't actually believe that at the end of the Royal Commission, we actually achieved that. I think the Royal Commission got so overwhelmed and the politics of the Royal Commission was such that they ended up making a set of recommendations where they essentially treated aged care as a silo. That's the last of my formal presentation, and I'll leave this on if people do want to actually take that down that web address, although we will circulate this, where you can get all of our RUCS reports, and here's also the link for the journal paper we published explaining the AHSRI classification in more detail, and also talking about how it performs technically. And on that basis, I will stop and happily take questions.
Thank you very much, Kathy. That was a really good overview, and I feel like it definitely, for me, has provided more insight into the star rating and the AHSRI and the alignment with the federal budget as well, and also what we need to do moving forward, and some of those things coming about. We do have a few questions in the chat room, so I'll just start with the first one, which is from George. He has said, with more complex cases in aged care and lack of access to dedicated health resources, what do you think is the role of aged care specific telehealth services to provide access to clinical services in residential aged care?
I think the area that the Royal Commission failed, and therefore the government failed as well, was actually on getting the health aged care interface right. And the Royal Commission failed because it didn't actually recognise, it made a punt on allied health, for example. It proposed a whole lot of new allied health items and proposed that they be funded by the MBS, and they proposed a whole lot of enhancements to medical and allied health, all to be funded by health through the MBS. That was a really naive idea. The government was never going to agree to that, and they didn't. People in aged care can use telehealth in exactly the same way that anybody else in the general community does, but everybody needs to understand aged care homes are not even paid to do the setup at their end. So there are some new items coming in the MBS that will improve general practice, resourcing of aged care, but it's not a solution. It's just going to be part of one of the many adjuncts that I think are available if people want to use it. And it's medical only. There's really no items that have been agreed to for allied health. And I certainly also tried and pushed very hard to get them to recommend the introduction of nurse practitioners in aged care, specifically in aged care funded by aged care rather than by health. And the Royal Commission really lost the plot at the end, and they really ended up, I think they were just too overwhelmed by the task, and so all their recommendations treated aged care as a silo rather than looking at the interface between them. How does the model take into account medical clinical interface? They're completely separated. I mean, the Commonwealth really has responded, and the Royal Commission set it up for them to treat aged care and primary care as silos, and the GPs, there are some incentives now in the model for GPs to do a better work in aged care, But one of the problems we've got, it works really well in a country town where you've got a little general practice and all the people go to the one nursing home. And in my region, you know, here in Wollongong, a person can go into an aged care facility and there can be 40 facilities within the catchment of a general practitioner. And realistically, they're not going to go into all of those sorts of homes. So I think the work in primary care is very much a work in progress. The same thing, I think, in terms of medical specialists. There are a lot of people in aged care who should be getting access to psychogeriatricians, neurologists, a whole lot of other medical specialists, and that is completely unaccounted for in the funding model, and that is purely based on nice states and territories agreeing that their aged care services will provide some in-reach, you know, opera type models, because there's no provision in the Commonwealth thinking for medical specialists to have a role in aged care.
Thank you, Kathy. So just moving on to the question from Jackie. She's got, from your perspective, what types of factors should the IHPA consider when determining price, and how should they take into account the consideration of the future quality of care required rather than current practice?
Yeah, and in fact, IPA is already having that thinking, and in fact, I actually met with them yesterday to discuss that very issue. There's a couple of issues for IPA. One is the classification, and the classification's fine. They don't need to do anything in that space. The second is the relativities between the classes. The relativities, even though the sector is demonstrably underfunded, the relativities between the classes are basically right. And I think the third thing is then the total quantum. The government has taken the easy way out on pricing by saying they're not a party to the staffing ratio, to the staffing pay raises, but that IPA will deal with those. So IPA now has to determine a fair way of determining a dollar value for one. You know, when I was using an NWAL of 1 or 100%, they need to take into account fair pay for workers as well as fair outcomes for residents. And there's two ways to do that. One is the first price they set and how to get that right. And then the second is how do they index that each year. They have been asked to do a costing study, and the problem with the costing study in a sector which is demonstrably underfunded is that it's very regressive. All you do is go out and cost inadequate care. And they're very conscious of that they need to actually move beyond funding inadequate care to funding adequate care. And I have to say that if somebody had told me 5 years ago that I'd be an advocate for staff ratios, I would have thought that was ridiculous, because I've spent my whole life arguing that we shouldn't be looking at either inputs or processes, that we should be looking at how to drive the system by price incentives on outputs and paying for quality and safety outcomes. But the single easiest way to improve quality and safety in aged care is mandated staff ratios and paying staff a fair wage, because both of those will increase the funding. 80% of all aged care costs are in salaries and wages. This is not a sector that's got a lot of other stuff going on. So I think, Jackie, the easy answer to your question is pay staff enough to recruit really good quality people, invest in them and have enough of them, actually pick up those issues of staff quantum, staff mix, clinical governance, and also do something about getting rid of this highly casualised workforce where people are, the sector has been structured in the best interests of providers are to have a whole lot of workers who each work 1 day a week in 5 different homes, and nobody's responsible for their study, for giving them any sort of permanency, and nobody's responsible for their professional development, giving them sick leave, study leave or anything else. And that's why you saw COVID spread so rapidly in Melbourne, because the predominant workforce model is a whole lot of casuals who go from home to home, being paid less than if they worked at Woolworths. So we can all talk about how you pay for outcomes, but the reality is if you don't have adequate inputs, you can never get the right quality and safety outcomes. And So that's why I started my presentation with that slide that said you've got inputs, processes, outputs and outcomes. And I can't believe that I've ended up being the biggest advocate for inputs, having argued against it all my life. But I actually think in the case of aged care, which conceptually and in terms of governance is a good 20 or 30 years behind healthcare, that's the only way to get an improvement in the short term.
Yep, excellent. And I think the next question sort of carries on to where you were talking to, Kathy. If ANAC is to be implemented like the Casemix system, we fund public hospitals. What is the mechanism that will ensure nursing homes improve their efficiency? So put simply, how to ensure that funding is directed to care rather than to shareholders or the bosses? Yeah,
well, I actually argued unsuccessfully to the Royal Commission that the Royal Commission should recommend a no-profit care policy, that the funding that homes get for ANAC has to be spent on care and they have to acquit that expenditure. And that if homes want to make money in the base care, you know, in their daily fee and in their accommodation, they can do so, but that the ANAC, the care component, should be not for profit. The Royal Commission rejected that. They said it wouldn't give homes a good incentive. So this goes right back to if you assume that you can improve aged care through a competitive market, and they did not challenge that assumption. And that was one of my slides. I don't believe we will fix aged care. Well, we still believe that the way to drive quality and safety is through a competitive market. And so, no, they all got, one of the things that was in the budget was a $10 a day increase. That really came from Stephanie Alexander arguing that they needed more money because of half of the residents in aged care either having malnutrition or being at risk of it. And Stephanie ran a fantastic campaign, the $10 a day to improve the quality of food. There are no conditions on that at all. Providers can claim that straight off the bottom line as profit going to their shareholders, and the government put no conditions on it at all. The really good thing about the staff ratios, and which is why I've become so such a fan, and I was the one who did the evidence in the Royal Commission arguing for it, is because that actually means they have to spend that money on staffing. They actually have to do that. What I did argue for in the Royal Commission, though, was that we adopt the American system where homes have to submit their payroll data to verify that they've actually spent it on staff. The Commonwealth response waters that down, and homes have to do a report every 3 months. So even when they adopted the principle, they have already watered it down to reduce accountability for the principle.
Yeah. So, and just moving on to the next question, Kathy. Yeah. Are you able to explain how oral healthcare needs is factored into the ANAC?
Yeah, look, I'll do it in two ways. One is this question is asking within a framework that's thinking about AHSRI. AHSRI had all these items, and the more items you got, the more points you got. ANAC is a global assessment. There's not items for pain and a separate ones for oral health. But oral health is another area where there is a lack of clarity about what is the boundary between aged care and healthcare, and oral health, like allied health, completely missed out between the two. So if people's oral health needs are met, it's because there's a private dentist or some private arrangement for their oral health, rather than because it's actually built into the funding model. We did recommend allied health staff ratios, which included oral health, and that was not accepted because the Royal Commission decided to punt for it through the MBS. So oral health hasn't been included, and that's because there is this schism still. Allied aged care is still in the government's eye a silo, separate from the rest of the health system. There's a question about confidence. I'm confident the classification is really good. I have no confidence in the Commonwealth's ability to implement anything. The devil's always in the detail in implementation. I would have been much more confident if the government had adopted our recommendation to require aged care providers to submit their payroll data to verify they'd actually recruited the staff, rather than to rely on a report from the homes every 3 months. This sector has a long history of collusion between providers and public servants in Canberra, and all of the rules and regulations have been watered down over time based on providers lobbying the Commonwealth Department of Health, and I have no doubt that that will continue into the future. So I'm not confident at all, Sandra, in answer to your question.
Excellent. And so this one, I'm not quite sure but it's got what factors underlie the de-skilling of the workforce?
Yes, I think there's two factors. One is in our history, that when we had a low care sector and a high care sector, the low care sector was always a de-skilled sector. It was the old hostel sector. And the nursing homes were the ones that actually had a skilled workforce, and they were regulated by states and territories. When the two sectors were brought together, they were brought together under the control of the Commonwealth, and they regulate the aged care sector now as though the whole sector is low care. And so all of the mandated staff ratios, quality standards, et cetera, that existed when the states and territories used to regulate not just the nursing homes they run, but also the private sector. When the Commonwealth took control, that function was taken away from states and territories and given to the Commonwealth via Janet Anderson's Quality and Safety, Aged Care Quality and Safety Commission, and they deregulated all the standards, so there's no staffing. Getting the 40 minutes and the 16 hours a day of RN is a really important precedent, because this is the first time the Commonwealth has ever mandated anything, and the previous mandating was done by the states and territories. And I have to say, if I go to Victoria as a natural experiment with COVID, the Victorian, for those who don't come from Victoria, Victoria is the one state that's maintained a very large number of state nursing homes. They run 178 nursing homes that are run by the Victorian Department of Health as state nursing homes. The rest of the states and territories have basically divested out of nursing homes over the years. Victoria, 685 people died in private nursing homes in Victoria. They had 10,000 cases or some ridiculous number of COVID. They did not have one death in any of the 178 public nursing homes in Victoria. And the difference was staff ratios and minimum standards. They are mandated for 6 hours a day. And we were reviewing homes for the Royal Commission. We actually reviewed one home for the Royal Commission who rostered for 6 minutes of registered nursing per resident per day. Just extraordinary. And they were completely accredited by the Commission.
Yeah, thank you for that historical overview as well. That's been very interesting. And the other thing, moving on to the next question from Alan, you mentioned regulation of profit in aged care. Do you share a similar view about regulation of profit in the private healthcare sector? So
no, look, I do in some aspects of it's not a general ideological view, but I don't actually believe that aged care is a market. And in fact, the Commonwealth has fallen over itself to make sure it's not a competitive market. It says we've got consumer-directed care, but for example, it has always resisted it. Even when the Royal Commission, even when in the middle of the COVID crisis last year, the Commonwealth would not provide publicly a list of the homes that had COVID cases. So it's not like GPs or pathology or private hospitals where there actually is choice for consumers and some ability to shop around if you don't like it. You are talking about a cohort. You saw it, 70% of people have got some level of cognitive impairment. It's not like buying a fridge or changing GPs in a town that's got 30 GPs, where you've got these monopoly arrangements and where people are so fragile and frail once they go into a home, they are absolutely in a vulnerable position, and they're much more vulnerable than they are going to a GP or getting a pathology test or going to a private hospital. And they're living there to the end of their life. And that's why I'm saying I think we need to regulate it as a public good and not see it as a commercial market, because it isn't a market. The other thing about it is that it's 80% funded by government. So this, there's no price signals in aged care.
The next question from Bronwyn asks, in relation to care time by class, did allied health include lifestyle coordinators, and did you break down the different allied health disciplines?
The answer to that is yes, they did. We did include lifestyle coordinators, and we did actually collect the data by different allied health disciplines, but we didn't report it that way. And we didn't do that because, again, it's so regressive. Because there are so few allied health, we were really concerned that people would see that that was what was appropriate rather than what already is. Basically, what you see in aged care and allied health is physiotherapists, and the groups that I think should be there, the podiatrists, the speech pathologists. These are so rare, and if they are there, they're coming in as private contractors rather than being built into the fabric of the aged care facility. And again, it's that issue about what's health and what's aged care and the boundaries. The other thing, going back to that previous question as well, is that you've got a whole cohort of people in aged care who've been paying private health insurance for 40 years, and that basically gets torn up the minute they go in, because when you look at it, people in aged care for some reason get almost forego anything with their private health insurance. And so the insurers are completely off scot-free once somebody's in a home.
We just have time for a couple more questions, but the next one is there a need for a new model of primary care for residential aged care facility residents?
Yeah, there is, and I think the new model for primary care is not based on GPs. I think it should be based on nurses. I think we should actually have capitated, from what I would like, capitated nursing homes run by nurse practitioners who've got prescribing rights and the right to order diagnostic tests, partnering with a general practice. Are we likely to get that? No, we're not.
Yeah. And the next one is more, I think, more of a statement, but also a question: how did the US achieve better quality than Australia, given that they have more for-profit homes, which is 70% in US compared to 35% in Australia?
Yeah, it's too long a question to try and answer here, but it's actually
yeah.
But I think the thing I would say, the Royal Commission commissioned a series of extremely good research reports. They're all sitting on their website. But if I had to generalise across, and I will generalise across all those because I peer-reviewed nearly all of them, overall, the public nursing homes in Australia have the best quality care, the private for-profits have the worst, and the private not-for-profit are in the middle. And that was the trend in cost, in quality, in safety, and all sorts of indicators across all of the reports that were done, that the Royal Commission either posted or actually commissioned.
Yeah. Well, and unfortunately, we don't have any time to answer the remaining questions, but we thank you very much for everyone for posing all those questions. They've been very insightful, and also wanted to say thank you to Kathy as well for being part of the webinar today and answering all these questions. It's been a great discussion, and we have learnt a lot during this time. Just a quick thing is the recordings will be made available, and you'll be provided a link to this, and you'll also receive an invitation to our next webinar. So we just wanted to say again, thank you very much, Kathy, and apologies for those questions that we didn't get to today. But yeah, and thank you very much for joining us today.
Thank you. It's been a pleasure.
Yeah, thanks, Kathy.